Hi, it's me, Dr. KT, and welcome to ODDDUCKSCIENCE. Science. And today we have a guest, yay! Dr. Bryce Ratliff, who is also a Hamptonian. You know it. Now, this month is June, and I know it's towards the end, and it's Men's Health Month. So we couldn't have ODDDUCK Science without bringing someone in that looks like me, that looks like you, to talk about some men's health issues and some preventative care. So I'll let Bryce introduce himself.
Sure. First and foremost, Crystal, thank you for having me on your platform. My name is Dr. Bryce Ratliff. I am a 2011 graduate of Hampton University, Onyx 8, and a 2016 graduate of Boston University School of Medicine. I am a family medicine doc. I graduated from New York Medical College, and I've been in New Jersey for some time practicing inpatient medicine as a hospitalist and also dabbling in outpatient now, which is pretty much my full time gig. I have a hybrid model job, so I do both clinic and hospital. That's the best way to describe it. So thank you for having me.
Of course. Now, I want to have a conversation. I have so many questions, as all of my ODDUCK Science scholars know. And so, who else to ask than a professional in the actual setting that sees people that look like us every day? So, one of the things we talked about a few weeks ago was the high prevalence of heart disease in the United States for all Americans, and also that now we're seeing it as the number one cause of death in Black men. Can you speak to that? Like, what are signs and symptoms that we need to look for, and how can we get into preventative care?
Yeah, so that's a huge topic. I think when you enter disease and therapy in medical school, cardiovascular disease or the cardio subject is one of the first ones we tackle. And the first thing you learn is about statins and cholesterol inhibitors and the HMG-CoA reductase blockage, and that's the enzyme that the meds target. But what I've seen in clinical practice is that heart disease is silent first and foremost, and so you're not always. I think the vast majority of people who may have coronary artery disease or an elevated calcium score, they don't know until the event shows up, right? And so, what does that look like? And generally, the two types of events we're talking about are a myocardial infarction, which is also known as a heart attack, and then a cerebral vascular accident, also known as a stroke, right? So, same mechanism of action. You just have these plaques that build up over time. And what we're seeing now more so is that it's occurring at an earlier age. And so you're checking in your 20s and 30s now. Not we're not waiting until the event occurs. And so I had my personal awakening this year. Again, I didn't have an event, but I think being in residency and being errant with eating kind of put you in a position where I could also be a subject of that had I not kind of corrected the ship or the direction of the ship, so to speak. So I'm big on my diet, big on my morning smoothie with my fruit. If you need a cholesterol inhibitor, I say go that route. I know I hear a lot of negative things about it, but preventative measures are so much better than trying to do things on the backside. And so we spend billions of dollars on tertiary care in this country. Meaning, what do we do after the event, which is much more dangerous than what can we do up front to prevent the event from happening. So primary care, I wish we were taken more seriously, but I think we've kind of put that on the back burner in this country, and yeah, that's why you see so much coronary artery disease.
Well, you said something interesting. You said you should start getting checked in your 20s and 30s. I have nephews that are in their 20s and 30s. So, what conversation should they be having to go to their primary care provider? How do you even have that conversation?
Well, it starts with truth, right? And so, one way to assess your need is like, again, anybody who's obese. Obesity is a huge risk factor. And then we tap into their family history too. So, if you know you have a strong family history of heart attack, stroke, hypertension, diabetes, they all run in a cluster. And some of it is due to genetics. Some of it's due to dietary habits and sedentary lifestyles, lack of exercise, and chronic stress. Right. So chronic stress accelerates all of these things simultaneously. And so you need to tell your nephews and young men of that age, maybe it's time to get my lipid profile checked. And so they're coming out with more novel cardiac and cerebral markers that can kind of determine your risk for diabetes far in advance. So fasting insulin is huge. It can give you like a 10-year buffer before you're in full blown diabetes. ApoB is a huge one that tells you your immediate heart attack risk. And LPA tells you your genetic heart attack risk, and you only need that once in a lifetime, right? Because that risk is not going to change. But if those are elevated, or your homocysteine is elevated, or your high sensitivity CRP are elevated, that tells you you're at risk. I felt at risk, bloated, not sleeping well, high cortisol, high stress. That's not good over a long term, period. And so you spend a decade with those things, and then they're just cooking under the surface until something happens. And again, I'd rather attack it up front because there's so much that goes into recovery, and recovery is not just your physical body; it's your spirit, right? And so a lot of people are so hard on themselves when these things happen. But if we can have the conversation now, we can prevent a lot of it.
So you listed a whole panel of tests. What do men need to ask for when they go into the office? And also for all of my ladies listening, because a lot of us, we have partners, we have fathers, we have uncles that we want to support and make sure they're going to the doctor's office. So what panel should we be asking for in case they don't remember homocysteine and APO and all the other tests that you named?
I know those remain at the top of my list, to be honest. So ApoB is probably number one, and you want that annually. LPA, like I said, you're just doing one time. Homocysteine annually, and high sensitivity CRP annually. Lipid profiles are the most common ones, but I feel like that under investigates, the LDL, right? So you get this LDL number, it could be high, it could be low. But there are folks with low LDL from the typical lipid panel who can still have a heart attack, right? It doesn't tell you like the composition of the actual particle that's floating through your arteries. So when those particles stack, that's when you get that plaque. All you need is an embolus or a clot to go in the middle of that plaque, and boom, you're having an event. So those are the things we want to assess. Those are top of my list.
Okay. Now, I know that you were in charge of hosting a men's health summit at Metropolitan Baptist Church. Do you want to give us some of the highlights that you talked about and encourage the men that they should look into, other than the things that you already mentioned?
Sure. No, we had a panel of physicians to host our annual Men's Health Expo at Metropolitan Baptist on Springfield Ave, 124 Springfield Ave, if you want to show up next year. Yeah. Uh, and it was what an awesome, revealing time to have. We had a psychiatrist with us, Dr. Mercedes, and we had a urologist who's on the verge of retiring, but again, for the prostate cancer crowd, that's a big one. And then we also had a pulmonary critical care doc. What I pitched to them is a primary care doc is essentially the point guard. So I'm like your Jalen Brunson for those Knicks and Five fans, right? And so you need a floor general to kind of dictate where you go specifically for a subspecialty. So if I once I get a patient who has chest pain, high blood pressure, cholesterol, I'm sending them to cardiology. Screening for colon cancer, you need a GI doc, right? So I'm sending you to a gastroenterology for a colonoscopy. If I get a PSA, a prostate specific antigen that's elevated, it's above 4, so normal is between 0 and 4, you may be at risk for benign prostatic hyperplasia or full blown prostate cancer, but I'm going to send you to urology, right? And so that's how we kind of convene different people or direct them, so to speak, once we find certain risk factors that are concerning. I have a low threshold. Again, I'd love to get ahead of a disease process and behind it. So we're not going to wait until you have a stomach mass. We're going to get you checked in advance. We're going to tell you to stop eating a bunch of, seed oils, a lot of, processed meat, sausage, sandwich meat, fried foods. All of those predispose you to risk, right? Cigarette smoke, um, and sometimes loneliness, like, the interaction that we have with other people. I know our pastor preaches fellowship, which I feel like is a kind of it helps deflect risk factors, right? And so, company, the people we see die early, I think, are lonely men, right? Women have a life expectancy of about 3 years longer, and I think it's even worse for African Americans, right? So that gap is even worse. My eyeball test tells me that women just take better care of themselves. To be frank, I see a lot of women in the gym. I see a lot of women with green smoothies. I see that's just what y'all do, and we don't. And so, whether it's an Iron Man complex or whatever, we need to close the gap. So I myself am closing the gap with my vitamin D, magnesium, all those things, and yeah. So
You
along with mental health.
you mentioned something about seed oils. What are seed oils? You said avoid those.
Yeah, so it's just It's a type of oil that in layman's terms, that the body's just not accustomed to breaking down, and so it accelerates those cardiovascular issues, right? It accelerates the formation of those plaques. We can't really make it into anything useful, so sometimes it turns into the cholesterol. So that's kind of my poor man's definition of what a seed oil is, and yeah, and so we want to avoid that. The processed foods, high fructose corn syrup, things of that nature that accelerate insulin dependence or insulin resistance rather, then turning into diabetes. So yeah.
I get that. And I understand exactly what you were saying about the comparison of men and women. I feel like women, we have a great ability to kind of draw to each other and pull off one another and share when we're going through hard times, share when things are difficult, share when things are great. We form bonds very easy. And I sometimes feel like that's a struggle when it comes to men. And like you linked earlier and you were talking about loneliness, we're seeing an increase in rates of suicide among Black men than we've seen in the last 20 or 30 years. Do you care to speak? I know that's not your expertise of why you think we're starting to see those increases.
Yeah, so it's interesting. So I do telehealth in Kentucky. And one of the things I noticed is, like, while these things are not my specific subspecialty, when you're in rural areas or when you see people in need, they often can't get to the specialist. So I become that default psychiatrist, so to speak. It is always my job to practice within the scope of, what I've been endowed to do, which is family medicine. But that it's so expansive and people have so many needs. But from my personal experience, we can just shoot back to COVID. I was an intern in New York, living in the Bronx, and I'm at the epicenter of like this wave of this pandemic. And what it forced us to do, we made up generic rules. I respect the rules, but this was an unprecedented event, and so we had to separate ourselves by 6 feet, stay home for extended periods of time, and it really killed social life for so many people. I had people come to my office after the wave of COVID. I remember specific men saying, I go, "Hey, what's your chief complaint or what's your concern?" And they told me, I've had a few guys say, "I'm just lonely. I don't have anyone." And so that's a diagnosis too, right? So it may not be a formal ICD-10 code, something that I can bill for, but that is something I need to address, right? And so what are you doing with your social programs? Are you singing in the men's choir? I do several things, in my personal life to try to, like, kind of quell loneliness. And so you're not making irrational decisions, doing things that won't benefit you at all, right? You want to find yourself with the right crowd, engage in volunteering efforts. And I encourage the young men who are there, really tap in and humble yourselves and figure out how you can be service to the community at large and not just, self-serving. So, and surprisingly, that helps fill my cup. I love to see people do better. And yeah, yeah.
Oh, good. So, okay, so you're promoting that we need community because I think that's one thing that we don't talk about as much. I think now, in I hate to say my age, the digital age, we feel like we're so isolated and we can do everything by ourselves, but we really can't. We actually need community to lean on one another. We were never created to be an island and to be self-sufficient. So we definitely need community, which is why I'm so glad we get to have you here and I get to ask you all the questions. And so I have before we even start to wrap up, is there anything that you would want to say that you would like to see men to do beyond the panel that you listed and beyond trying to create community? What else is something that you would like to see men take a leap towards and when it comes to prevention?
So there are tangible things and non-tangible things that I practice in my own life, and then there are things that are physically more understandable, right? So, kind of tapping into that loneliness thing. Social media is not a real relationship for me. And I think we kind of have conflated that with like genuinely reaching out, genuinely checking on people. When I grew up in the church, we had a sick and shut-in ministry and
Mhm.
require people to go visit people who were stuck in their homes. And that social interaction, you can even count this as social interaction in the sense that, like, we're talking to each other through a platform, but about real tangible things that are going to benefit us in a healthy way. So let's, re-engaging each other, taking your vitamin D, right? Darker skinned men, black men, and people in general have a harder time getting adequate levels of vitamin D, which it's like responsible for 2,500 genes. bone density, testosterone formation, progesterone formation, serotonin, dopamine, so many critical things that we need. And I wouldn't say it's a quick fix, but it's certainly an easier fix than surgery. It's certainly easier to fix than chemotherapy. It's certainly an easier fix than radiation. And so if we can do those things and be consistent, challenge yourself to be consistent. We both of us didn't become doctors overnight. We had to do our due diligence on a day by day.
Yeah.
And I think people think they can escape it. Everyone wants to escape pills, but I tell you this much. I say this normally to patients. On one side or the other, you're going to take pills. And so if you can take your magnesium and vitamin D on this side, maybe you don't need to take your blood pressure med on this side. All of those are risk factors for insulin resistance. Maybe we can avoid diabetes meds in the future too. And so those are the things I would encourage. It's just like to really get ahead of it, get ahead of suffering, because it only compounds the things that could be worse in the future. And I think also on the inpatient side in the hospital, I've done a lot of hospice and palliative care, and I guarantee you that a lot of the people that I've had to put on a Dilaudid drip or a morphine drip to allow them to pass without suffering would benefit from having done these things early on in life. Stretching in the morning, absolutely going to the gym. You may not run a marathon, but what you can do is walk on a treadmill at a 10% incline, at 3 speed for 30 minutes. That's going to, after your meals, that's going to decrease your insulin resistance dramatically. That's where you can see that weight loss. You can see your face shrink. You can see your belly, your central obesity shrink. So, yeah, those are practical things that I would recommend that we start doing. There's so many other things we can do. I don't like to overwhelm people. We start at first base, right? So don't worry about the home run. Get on first base. That's the best way to attack primary care.
We like that. Get on first base. So then the second question, where are you practicing? If people want to partner with you, they want you as their physician, because again, you are a Black male that is a physician in primary care, and that is rare. I think the percentage of Black doctors, what is it, like 3% or 4%?
Yeah. 4%, and the vast majority, respectfully, are 85% of Black doctors are Nigerian, from what I understand too. So, which those are our colleagues. Those are I send readily send anybody to any of those physicians. But our African American experience is very different. There's a lot of pain, trauma, suffering in our community, and it's important for us to understand each other. And again, I want to reiterate that I'm not dismissive of any culture's experience, and we need any and all doctors. We need those strong Black women. I need those strong Black women who can correct me clinically and tell me where I'm wrong. Because often, I mean, we are, but it takes a collaborative effort. I will be starting in July 6th in Nirvana Health. So there are multiple locations. It's one not too far from me in Newark, Bloomfield, and East Orange. And so I can present you guys with some more details soon coming here. Again, that's outpatient, and I also will be doing some inpatient at some hospitals like St. Michael's and Claremont, but that's kind of in the remote future. But for now, yeah, Nirvana Health, East Orange, Bloomfield, and Newark.
Okay. Well, thank you so much, Dr. Ratliff. We appreciate you, and thank you for sharing your expertise. And as always, all of my ODDDUCK scholars, I hope you learned something today. Have a glorious day. Until next time. Bye.
Be well.